So apomorphine subcutaneous infusion should be used before advanced therapies are considered. And I hope in the next 10 minutes to convince you of this point, despite what Professor Power might add afterwards. Traditionally, our treatment paradigm has included apomorphine subcutaneous infusion pump as one of the 3 advanced therapy options for our patients with Parkinson's disease. Indeed, a recent review in JPD this year by my friends and colleagues identifies that when oral dopaminergic medications fall short, patients may benefit from one of the currently available advanced treatments, namely DBS, CLIG, or a continuous subcutaneous apomorphine infusion. And they point out clearly that the indication, the choice between the separate advanced treatments and the timing can be challenging. But apomorphine subcutaneous infusion does not require surgery. It doesn't require surgery to insert a percutaneous intragastric tube, and it does not require surgery to insert intracerebral leads. And this is important. It's of more than passing interest, I think, to reconsider this paradigm of having 3 advanced therapies, because we know that surgical therapies remain underutilized. Many patients fear surgical options. Surgical insertion has perioperative risk, and the surgical advanced therapies, both DBS and LCIG, can have longer-term risks and adverse events that occur over time as well. In contrast, apomorphine subcutaneous infusion pump does not require surgery, nor a surgeon. It's placed and removed daily by a patient or a caregiver. Its insertion is safe. It has effective treatment for motor complications, as we now know from randomized double-blind placebo-controlled TOLEDO trial. It's safe and well tolerated in the long term, both from the open label extension of TOLEDO and from the US infusion long-term safety study. Subcutaneous reactions occur but are readily managed and are constrained both temporally and in location. And this therapy has durability over time. So apomorphine subcutaneous infusion pump can be prescribed earlier than these other surgical advanced therapies when oral therapies begin to fail to maintain a consistent good on throughout the day and the night. The insertion of the pump is simple within a small Teflon catheter that goes onto this from the skin here and connected by the tubing to the subcutaneous pump. There's nothing complicated about this. It's very simple to place and to keep on throughout the day. In the TOLEDO study, we saw a greater improvement in mean daily off time and on time without troublesome dyskinesia, good on time at all post-baseline time points versus placebo, as depicted so clearly in this graph. When we look at durability in the 1-year open label extension of TOLEDO, we saw maintenance of efficacy over the 64 weeks combined double-blind and open label. And this parallels almost exactly what we saw in the US safety study, demonstrating in the patients in this trial were able to maintain the improvements in off time and good on time over the 52-week period depicted here. And of course, for far longer, that has not yet been reported. Patients have been followed as well. Many patients remain on infusion for a year period. And we can see that those who have doses that are optimized may remain on it longer. And here we can see about 3/4 of the patients in TOLEDO and about 2/3 of patients in the US safety study remained on therapy at 12 months. In the TOLEDO study, global impression scores by patients and their caregivers, the PGIC, demonstrated improvement in many of the patients, whereas those on placebo did not realize such improvement. And this improvement probably reflected the good on that occurs. We saw a reduction off time, but it's replaced with good on without troublesome dyskinesia, and also on without any dyskinesia. And we can see here also that about over 80% of patients, when they had on time, that when they were awake, that was an on time when they were on this pump. Other secondary endpoints reveal over 400 milligram reduction of patients in the apomorphine continuous subcutaneous infusion dose, the LEDs were reduced. About 345 milligrams over placebo, but over 400 milligrams. So we see the same reduction in levodopa equivalent doses as well. Even in patients who are being treated with DBS, those waiting on the list to be getting this advanced surgical therapy, those who have had it removed or had to have it off because of a break in the lead or a device removal, those who lost effect and then didn't have the full efficacy, we can see improvements when we add on the apomorphine infusion. So we know that this is an effective therapy. Indeed, as in contrast to the blue ups and downs of oral therapies, these on and off fluctuations and levodopa levels in the bloodstream, we can see in the red the very consistent replacement of a dopaminergic therapy, at least in the plasma, that may provide more continuous dopaminergic receptor stimulation, a goal of our treatment paradigms for so long. And in a study done by my colleagues in Europe and Australia, demonstrated that having this continuous subcutaneous apomorphine infusion may indeed reset those pathways and reduce both dyskinesia during infusion, but also make it more difficult to provoke dyskinesia once the therapy is interrupted. And they were able to show by a levodopa challenge and by an apomorphine challenge a reduction in dyskinesia compared to prior to the 3-month infusional therapy. These findings support the idea that replacement of the discontinuous oral therapies with the continuous dopamine receptor stimulation using the continuous subcutaneous apomorphine infusion may reverse the sensitization process that may underlie some of the development of levodopa-induced dyskinesia. Safety is also important beyond efficacy and durability. In a TOLEDO study, we can see many of dopaminergic side effects that we've come to expect with our dopaminergic therapies, nothing that's surprising. Skin and subcutaneous nodules do occur. Many patients get these. But again, these are usually last a day or two. When they occur, they can be circumscribed. They often go away without any type of erythema or bruising or infection, and can be readily managed over time. In the TOLEDO open label study, no new or different adverse reactions occurred over the 1-year period, mirroring what we saw in the U.S. safety study, the open label safety study. And again, while we see infusion site nodules, they're limited in time and space and can be managed usually with little difficulty. The other dopaminergic side effects can occur during titration, less so during the 1-year maintenance period. So when should this effective, safe, and durable treatment option be considered for our patients who are failing to have a consistent good on, despite polypharmacy with dopaminergic and non-dopaminergic medication, longer-acting levodopa preparations, on-demand therapies? And when should we think about using this type of device where we have the apomorphine that can go into the pump and be administered through this small catheter that applied to the skin each day and can be used during the waking day or a 24-hour day if one desires? Well, I think that our treatment paradigms may make patients not consider this when we lump them together with advanced surgical therapies that they fear so greatly and carry with them risks. I think we begin to think about an intermediate non-surgical category that occurs when patients fail to have a continuous good on time despite a combination of adjusted levodopa orally, extended release preparations, adjunctive dopamine agonists, transdermally and orally, inhibitors of COMT and MAO, non-dopamine agents, on-demand therapies that are non-oral, trying to turn an off back into an on in the morning or throughout the day. In contrast, giving a continuous subcutaneous infusion of apomorphine is a therapy that should occur much sooner than we begin to think about using more advanced surgical therapies that require insertion of intracerebral leads and gastric tubes. This category would allow patients to think about trying this and using this and seeing what it feels like to be continuously on much more during the waking day. I think thinking about oral and non-oral therapies and intermediate therapy that's non-surgical would come far before thinking about and scheduling advanced surgical therapies that are held in reserve for patients who do not do well or have an adverse event or suboptimal efficacy on a subcutaneous apomorphine infusion. I listed here also in clinical trials because our patients are getting them now, levodopa subcutaneous infusions as well. So yes, I think apomorphine subcutaneous infusion should be used before surgical therapies are considered. The traditional paradigm should be updated to reflect the newer subcutaneous infusion technology that's available to our patients. That seems to be easier to administer and put on and to use. It has established efficacy now. In double-blind randomized trial, it has demonstrated safety over prolonged periods, both in Europe and in the US, demonstrating long-term safety, tolerability, and durability. So thank you, and hopefully Professor Pawa will not change your mind back.